Well, good morning, everybody, and thank you for joining us for the SeNT eReferral live demonstration webinar. My name is Sandy Vincent from the education team, and I'm joined today by Peter Mullen, Digital Health Officer for the PHN, who will be presenting our live demonstration. I'd like to start by acknowledging the traditional custodians of the land that we live and work on, and pay respects to their enduring culture and contributions to the life of this vast region. This session is being recorded, and that recording will be available on the PHN Education Library within the next few days. If you have any questions during the presentation, please pop those into the question box and we will review those at the end of the session. And an evaluation will come to you directly after the session. Please do complete that for us, as your information is very important. So thank you, Peter. I will now hand over to you to begin your presentation.
Great, thank you, Sandy. I'll just share my screen. Can you just confirm that you can see a web browser there that shows the SeNT referrals?
That's perfect. Thanks, Peter.
Okay. Alrighty. Okay, so thank you everybody for coming along today. What we're going to do today is just run you through creating a SeNT referral and then also what happens to that SeNT referral. So the SeNT referral system is a joint project between the Primary Health Network, Hunter New England Central Coast Primary Health Network, and Hunter New England Local Health District. Started back in 2016, and the basic concept behind the project was to look at developing a process or a methodology for transferring referrals between primary care providers and the local health district, as well as private providers, in a secure method by encrypting that and obviously replacing faxes and because fax technology is ancient technology. Really, we're looking back at the 1980s and it doesn't play nicely with the NBN. So looking for an alternative to that, and also looking for an alternative to emails because obviously emails not secure in most cases, not encrypted. So looking for that secure point-to-point safe method of transferring patient information. So with the SeNT referral system, it's actually the software provider is BPAC Clinical Solutions. They're a Kiwi-based company or New Zealand company, but all of the data is stored in Australia. The product is only available at the moment in the Hunter New England part of our footprint for the PHN, but we are looking at alternatives for other areas, and that's a work in progress. The product itself has also been adopted by Queensland Health as a statewide solution in Queensland. So it is quite a large product and very well known across different areas. And I know BPAC are also tendering for other states. So the product has a lot of integrity, but it's also going through a lot of development. And that's something we remain part of. It's essentially a clinical decision-making tool. And you'll see that becomes a little bit apparent as we move through creating a referral. It integrates with both best practice and medical director. So that's about 90% of practices across our footprint at the moment. And what that means by integrating it, it actually pulls information and extracts information from the patient file, which means that the practitioner doesn't need to complete information along the way. They still complete part of it, but there's information that's relevant to every referral, and we try to extract as much of that to reduce the workload for the referring clinician, and also to improve the quality of the referral so that the receiving service receives information that they would expect to receive that is pertinent to that referral. The forms that you see, the web page that you see in front of you, it will actually vary depending on what specialty we choose or what condition we choose, and I'll demonstrate a little bit of that as we go through the form. But you can see up the top of the form, it's pulled through the patient details, gives the patient name, date of birth, so that allows the clinician to have a look at that, make sure they're referring for the right patient. Default setting is for 12 months, but the referral can be changed to an indefinite referral. There are also, it defaults to new referral, but you can see that we can also do an extension of care. We can request participation in a team care arrangement, and we can also have another referral. But I'll leave it just in the default setting for now at new referral. Where it differs to a normal referral or a way that a GP has traditionally created a referral, normally they'll start typing a referral. They'll have it in their head who they're referring to. So they'll start typing out, "Dear Dr. Smith, thank you for seeing Mrs. Jones regarding whatever condition they might be referring for." The concept behind the SeNT referral program is that we don't want a referral to go to a service or to an endpoint that doesn't actually fit that patient's need. And so for that reason, what we do is driven by specialty condition as the starting point. So what a clinician would do is they would start typing in a condition, might be gastroenterology, and all the gastroenterology conditions then drop down for them to choose from. So they can search by specialty. That might be start typing mental health, and all of the mental health conditions will drop down in there as well. So the more they type, it'll then refine that search down. The other way they can search is by condition. It might be drug and alcohol withdrawal, for example. We might grab that one. It's probably a good example. So that's the way it will actually choose, and then it'll filter down as we move down through the form. The algorithm runs in the background, and that will help filter out again, only giving us, and the idea is that we'll at the end, by the time we get down to selecting a provider, only a provider that meets the conditions above can actually be referred to. And the idea of that is to filter out with referrals to services that can't actually see that, and make sure the patient's getting to the right service first time every time. So we're asked to create an urgency here. Now, this is just the GP's first line of triage, so it's either urgent or non-urgent, and that in some cases can dictate, again, where that service will, where that patient would be referred to. We've got private or public here. Now, the definition here is really private is going to a private provider. Public is going to any service. It might be a local health district service, but it is also, public also contains services that our commissioned service providers fall into that public because there's no cost to the patient. Bulk billing, while there might be no charge to the patient, all fall under private. If a private specialist is doing bulk billing, it'll come under private because we don't know, that may change at any time. I'm going to select private today, even though I know we've got commissioned service providers here today, but the examples I'd like to use probably, I'm working in a test database, and not all of our commissioned service providers sit in our test database. You can see I've automatically been given Armidale, Tamworth, New England Northwest here. There are 5 areas. So again, in the normal live database, you would see that drop down, and you would be, if the service is relevant in that area, the clinician would be able to choose that area. It's only that I'm, as I said, working in that test database at the moment. So now I'm down, now I'm given a provider. So I can choose Craig Scott here. Again, limited providers in our test database. Patient consent date, patient has the consent to the referral, that goes in by default. Will the patient consider telehealth? Yes, we can put that in, and am I the patient's usual GP? From there, we then come down into the specialty clinical information, and you can see that this is specific to the condition that I've selected, being drug and alcohol, and you can see that there's specific things here that we're asking for. So why is the patient, what's the referral indication? Is it harmful or dependent? And with some of these, it'll drop down and ask for different information. So if it was chronic opioid use and deprescribing, it'll then give us more things. So the idea being that the form that we create, or the referral that we create, is specific to that patient, but also specific to that receiving service, to give them as much information that's relevant that they would want to see in a referral, to allow them to triage that patient in a timely manner, and not to have to go back to the referring service to get further information. If we change the specialty here, if we went to something like speech therapy, just says, yes, we're going to change the speciality. It just asks us, do we really want to do that? You'll see it resets the form. Again, if we go non-urgent, private, it'll give us a provider down here now. We've got a number of these providers in here. I might just go with Sophie Egan. And then you can see, when we get down to the specialty clinical information, it will then ask us what sort of referral type we're doing. So when we're doing things that fall under that allied health area, we can again tick that it's a chronic disease referral. That will then give us information about team care arrangements, GPMPs and things like that. And that sort of information. So you can see it then comes down, and also it meets the requirements for a GP management plan. So it's asking for those number of services, how many are we going to do? So we put that information in there, and then what sort of allied health professional we're referring to. And again, what's the reason for the referral? Is there particular information that requires it. Is it a swallowing disorder or something like that? Or if it's other, they can tick other and then type information relevant to that patient in there. So there's, as each form, there's not every condition has a specific form, but there's about between 250 and 280 condition-specific forms that we can actually drop down that we've developed over time. And we continue to develop those as we move through it. So when they get down further in the form, you can see they create a referral letter as well, but I might come back to that. If I just change the form here again, or the specialty, if we go anxiety in adults and choose psychology, and again, it's just prompting me to change that form. We choose private. We've got New Psych in here, who is a private psychologist company in practice in Newcastle. You can see again, it starts to give us particular things to that speciality or that condition. It's asking us now if we're referring, but it also gives some red flags. So if there's, depending on what that information is, depending on the patient's condition, it's saying if this is an urgent, if there's immediate risk, don't refer it through this service. Call 000 and refer to the closest emergency department, so that it gives guidance to the clinician as well. But if the patient fits that detail, it might be, yes, the number of services is 6 to 10, and then they might start typing their referral letter. So I'm just going to put the test in here, but that is where they'd actually complete, which is essentially what they would type into their normal referral letter if they were using a templated referral letter out of their best practice or their medical director software or the clinical software. All of that software comes with pre-made or pre-templated referral letters that the companies put together. So this is where they type in, "Dear doctor, thank you for seeing Penny Anderson regarding her anxiety," and give in all that information in there. And that's where they put the history, the examination, their provisional diagnosis, management to date, and things like that. You can see each time too that as I type something in, there's the red star over here to the left. Whenever we actually complete that box, it actually goes green, and that allows us to, it's completing the missing fields down the bottom here, and we then can move forward and actually submit the referral once all of those areas are completed. Again, depending on the specialty or the condition that's being referred, there might be investigations and reports that are actually particular to that condition. Here you can see it's prompting us for a mental health treatment plan. If so, the GP will have that on their file. They can actually attach that to the referral, and that will come through as part of the referral. If we were referring for a diabetes referral, it'll look for things like an HbA1c, full blood count, blood sugars, and things like that. So, and what we'll actually do, if it looks through the patient file, it'll actually, if it finds that report or that investigation, it'll actually attach that to the referral automatically, and the clinician doesn't need to actually attach that themselves. If it doesn't find it, if it's been received manually and scanned into the patient file, for example, they can actually go to the investigations and attach any document or any, it might be a clinical image or any relevant document that they've got on their file. And there's a lot of different file types that it will accept. It'll accept photos, it'll accept the comment document types, rich text files, documents, PDF files, TIFF files, JPEG files, all those sort of things can be attached. So as well as all, obviously, the common investigation type files. Once we move down through the form though, and again, you can see these are, if there's investigations that aren't necessarily relevant to the referral, but the GP, that aren't deemed essential to the referral, the GP can still add things on there. So you can see, we've got a skin allergy test that might be relevant to a particular referral or something like that. Again, if the GP ticks it, that will add that to the referral. We then move down into the standard clinical information. So this is any information that is general to most referrals. And again, the GP can go through and select what's appropriate and what's not. Allergies, adverse reactions you can see it's got a gold padlock here. That's always going to form part of the file, and it's a compulsory addition. So anything with a gold padlock, the GP will be included in the file. The only way to edit that is to update it in the patient file. Then it can be updated here in the referral. But generally, obviously, that's something that you want to go through to most referrals. We then get asked, is there any relevant medical history? So the GP can go through and tick anything that might be relevant. they can tick everything. They don't have to tick everything in isolation. But the reason we don't default by tick everything is, depending on the sort of referral, not all conditions or past medical history may be relevant to the referral, and that becomes part of the privacy situation. In a lot of templated referrals that come through from the practice software, it'll actually, the default condition will be to pick up all past history. Our view is that shouldn't happen. If you're doing a referral to a podiatrist, do they really need to know that you've had, a gallbladder operation 2 weeks ago? Do they need to know about a mental health situation or any other medical situation that may not be relevant to a podiatrist referral? So that's the reason why we actually don't default to ticking everything in that situation. Current medications, again, can be ticked and unticked, and you can see it's defaulting there to that, because in generally most medications are relevant to a referral, but again, it's a simple untick if the GP doesn't want to send that information through. They have the option of adding progress notes. Again, if they're relevant, they can just tick that and that will bring that information through. Immunisations, again, exactly the same thing. Then we come down to the patient details, so their height, their weight, their BMI, blood pressure, all of that information flows through from the patient file. Family history, and they can elect to take that out if they want to. If family history is not relevant, that can actually be deleted off the referral. Again, smoking status, alcohol consumption, just pulling through from the patient file, and that information will go through in the referral. Then gives you all the patient information, so we pull all that information through. What's their preferred method of contact? Is an interpreter required? If we tick yes, it will then give us a drop-down box where we can select a number of languages from. Are they an overseas visitor? And just things that are generally there that may or may not relate. The default position is no. The only thing that defaults to where it becomes compulsory is, are they in a residential aged care facility? If they're aged over 75, that becomes a compulsory field to tell the receiving clinician whether they are actually in an RACF or not. There's areas here for alternate contact details. So you can put in there, could be, carer, daughter, enduring guardian, emergency contact. All that information is there. So depending on the relevancy, that information can also be added. Automatically, we pull through things like Medicare, pension cards, DVA cards, concession cards. Health fund information, generally not recorded at a general practice level, only because it's not relevant to them, so they tend not to ask that information. But if that had been recorded, that will flow through as well, and that can be valuable for private providers if that information is there. Also asks if there's is it a work cover claim or is it a third party claim? If it is, then there's a spot there to put in the actual claim number and that information. Referring GP's information comes through, and then they can add any supporting documentation. So that could be, as I mentioned, a clinical image or something like that. So if we go here, you can see there's nothing from clinical software. Again, I'm using a test database, so there's nothing in my patient file. Attached from the computer, if they did have something like that, there's my last expense claim. If I go to pictures here, we've got some clinical images somewhere, so I can attach an X-ray to that referral or something like that. You can see we've got a missing field down here. They don't need to go searching through that. If they click on that, it will take them straight through to the relevant part of the form. You can see here we've got the red dot over here. If I tick here that yes, they've had some head pain, that's relevant to this referral, and that they've had a skin lesion, that automatically disappears. And you can see now we can submit the referral. So if we click submit, and it all happens usually fairly quickly. And you can see now we've got the referral. It renders very similar to a PDF. You can see the skin test has come through. It's quite easily readable. It's in a really good format for the receiving service, and it breaks down that information. It follows through all that information. Once we're ready to submit, the GP has the choice of print and submit. We usually suggest to our GPs that they don't print it. There's no need. A lot of these referrals, if you've got a number of attachments like investigation reports, they can run to 10, 15 pages. There's no need for that to be printed for the patient to take with them. Usually they'll only leave it at the bus stop or sitting in their car or something like that. So we suggest the GPs, they just submit that referral. So we click submit, tells us the referral is submitting, and then it says it's been successfully sent, and that we can close that window to exit. I won't click on that just at the moment. Now, with private referrals, what they do in most cases, they will come through to referral manager. LHD referrals go through, local health district, or a Hunter New England local health district referrals, go straight through them, and they've got a system that deals with that. As a private provider, and I know we've got a couple of our providers on here at the moment listening to this webinar, it may come through to referral manager. For some of the services though, for things like the centralised intake for mental health, the Primus service, that actually there's a different interface that works with that, so that doesn't come through to here. But I know also for those services, they do actually receive referrals into what we call referral manager. So this is the secure website where that referral will come through to. Now again, this is a test database, you're not seeing live patient information, but you can see that referral that I just created there has come through to this point. Now, again, what happens is when that referral is created, an email is generated by the system that goes through to the receiving service. There's no patient in that in that email. It is simply just an advice email. It gives them a link to this website. They click on that. They can put in their credentials, so email and password. They then log onto the system and they'll see this. Sitting in the background is a second factor authentication. That is, we install a security certificate onto any computer that is linked specifically to their account. It can be either a security certificate issued by BPAC or it can be a Services Australia NASH certificate. So depending on what the service has, we can use either of those as that second factor authentication. That just means that nobody, even if somebody got hold of the log on and password, without having that certificate installed on the computer that they're accessing from, they can't get in to see that patient information. As I mentioned earlier, the patient information is transferred encrypted using the current latest technology, and so it goes point to point and it can't go anywhere in between. So unlike an email or something like that, it can't go astray. You can't type it in to go to a different provider. The system will send it on to one. You can see when we click on that, and the difference between bold and unbolded is simply that the bold referrals haven't been accessed. As soon as we click on the referral, it goes to unbold and then brings up a menu down the right-hand side. If we click on the detail, you can see it then takes us into the referral, and the concertina buttons, again, look very similar to that outlay that we had when we were creating the referral, and all the information is in there. Depending on the provider, they can actually manage referrals here within the referral manager site. They can do things like add notes. They can add a unique reference number to the referral, so that might be their own patient file number or something like that. And they can also re-triage it. So if the GP has triaged the urgency as non-urgent and the receiving service thinks it's urgent, they can actually re-triage that and then adjust that within their own system. However, most providers, what they're really doing is effectively taking it out of this system. They're just using this as a receiving system and bringing it into their own clinical software. So in most cases, what they're going to do is actually just print that referral. Do we really want to print it? Renders the referral as a PDF. And as you can see, nice and easy to read all that information in there. And it will put all that information, and it includes the image that we've attached as well. So all that information comes through. From there, they can either print it as a hard copy, which some practices still prefer to do. Others, the more modern of the practices, they'll download it as a PDF, bring it up into their own software and manage it from there. So that's pretty much it. That's the system from end to end. Sandy, I might throw back to you and see if we've got any questions.
Thank you so much, Peter. That was excellent. I am just looking at the questions box and there isn't any questions in the box at the moment, but we might just pause and give everyone a chance to send questions through, or if anyone wants to unmute themselves and ask a question directly, then please do that.
One that sometimes comes up, Sandy, that I've been asked in the past is regularly, what about practices? Obviously, there's that roughly 10% of practices that don't have medical director or best practice as their clinical software. They at the moment can't use the SeNT software to send referral security. They can obviously use methods like fax or other secure messaging like Medical Objects, Argus or HealthLink. So they're still very valid ways of sending referrals. We are also, though, working with BPAC on what we're terming at the moment a non-integrated solution. So that will allow those providers to actually access the system. It'll be a web-based form, won't be quite as integrated as the forms we've seen today, where those specialty forms, but it will allow practices that have other types of software to actually send referrals securely using that SeNT software. So that's it. That's in development at the moment. I can't put a timeline on that at the moment, but yeah, hopefully we'll have that sooner rather than later. So that's a question that comes up pretty regularly. I should have mentioned too, for ease of access for GPs, when they create that referral, it automatically puts a copy of the referral onto their patient file, so they don't need to go and save that information externally or print it and scan it back into the file or anything like that. It's automatically saved into the patient file. And receiving services, they will generally access those. We do monitor all the referrals. That's the other thing I should mention. So while the GPs at the moment get confirmation of any referrals going to the local health district, for anything going to a private provider, they don't get a confirmation at this current time, but the referrals are monitored. Firstly, the system runs what we call a dead letter process in the background, and they'll monitor that, and it continually looks for something that's not delivered to an endpoint. If that happens, it re-queues it and tries to resend it a number of times. If that fails, then it actually flags human intervention, and we would investigate that and find out why it's not going through, and either get the referral resent or manage it that way. Referrals that have been sent are monitored, so I actually monitor those myself. So I regularly am looking at the live referrals to say, okay, has that referral been opened by the receiving clinician? And if it hasn't, I've got some protocols. If it's an urgent referral, 24 to 48 hours, I'll contact the receiving clinician, just make sure that they're aware that it's there, that there's no technical issue, and that they can access the referral, and then 48 to 72 hours for a non-urgent referral. So we do monitor those, and we're also building, again, some additional systems to help monitor those and make it easier for the receiving services.
Fantastic. Thank you, Peter. No more questions?
That was nice and easy.
Yes, it was nice and easy and perfect to time as well. So thank you very much, Peter. That was excellent. And as I mentioned, this is recorded. So for your colleagues, you can access that on the library to watch this again later. And if you have any further questions, just send them through to us, and we'll pass those on to Peter. So it just remains for me to say thank you very much for joining us, and have a good rest of the day, everybody.
Thanks, everybody.
Thank you.